Modern medicine is a wonderful tool. Functional medicine starts with good medicine. It's not a substitute for conventional medicine. It is a new model for treating chronic, complex disease. Functional medicine is not for acute care. As I mentioned, we're going to be in trouble if we try to treat acute MIs or acute CVAs or sepsis. It's not the right tool. And we need to vet these people. They come in with a million diagnoses, right? Because they have these obscure problems, and they come in, they say, well, one doctor said I had seronegative rheumatoid arthritis, and the next guy said, well, I think you've got fibromyalgia, and the next guy said, well, I think it's psoriatic arthritis, and the next guy said, well, I think it's mixed connective tissue disease, and the next guy said, you know what, I don't think you have any of that stuff, I think you're just depressed. So we got to vet this stuff. We have to figure out what tools we need to become the very best diagnosticians. So conventional medicine really equals big problems that need big interventions, and you have to accept big side effects. But applying the acute care model to chronic complex disease, it ends up in episodic care, fragmented care, more tests, more cost. Because if every tool you have, if every problem looks like a nail, or if the only tool you have is a hammer, everything starts to look like a nail. In conventional medicine, we think about naming it, blaming it, and taming it. But when we name something, does that really make it real? Can you cut rheumatoid arthritis out of somebody? And do drugs really fix problems in most instances? Well, antibiotics probably do fix one problem and cause another. But in the right instance, antibiotics are critically life-saving, right? But here's a scary fact. Depending on the paper you read, the proper use of medications, not medication error, not misadventure, the proper use of medications is thought to be the 4th to 6th leading cause of death. And that's because we're using them inappropriately. In acute care medicine, we name it. It's flooding. We blame it. It's water on the floor. We tame it. We mop it up. In functional medicine, we think and we link. And we wonder, what's causing this flooding? And we walk over and turn the tap off. So they are fundamentally different things. You can improve a candle all you like, it will never be a light bulb. It's not that functional medicine is better, it's different, and it's for a different purpose. So we have to rethink. We have to rethink medicine, we have to rethink disease. We have this guy, Hippocrates, the father of modern medicine. And this is a great paper about him and one of his teachers, Democritus. He's been dead over 2,300 years. Maybe we need to rethink modern. We need a new map. We have a great map. We have a wonderful map called acute care medicine. And it's a great map for acute care. But that map is for China, and we're in New York City. We have the wrong map for this problem. So we need a new map. And the map are the tools of functional medicine. So functional medicine is a system-based approach that focuses on identifying and addressing the root cause of physiologic dysfunction that contributes to disease. System biology is based on the understanding that the whole is greater than the parts. So we have this false dichotomy in research today. My son is a biophysicist at the University of Minnesota, and he's very reductionistic, very much so. He's trying to figure out how motor proteins work. And I said, didn't you take 7th grade biology? There's like actin and myosin, and they kind of like act like a ratchet. And he said, yeah, thanks, Dad. We're looking for a little more specificity. So, reductionism is knowing more and more about less and less until you know everything there is to know about nothing at all, right? Holism is knowing less and less about more and more until you know everything there is to know, nothing at all about everything there is to know. So, That's the false dichotomy. There's another axis here, and it's called systems. A biology-based interdisciplinary field of study that focuses on complex interactions within biological systems using holistic approaches, holism instead of traditional reductionism to biological research. You know, when I was a kid, you know, if my son is on the reductionism side, then any of you remember the Craigheads, the oncologists? I think they were out of the University of Colorado, and every blue moon they'd have a special on TV, and I was totally glued to it. And they'd talk about, you know, how the hoof prints of the ruminants were good for the prairie. Or they would talk about the sort of the broad concepts of ecology, right? They didn't get down to the molecular biology. So we've got holism on one side, and we've got reductionism on the other side, and systems approaches uses the tools of both to try to understand the systematic interactions. And that's what we're doing in functional medicine. From sick care to health care, re-engineering prevention into the U.S. system. This is from the New England Journal of Medicine. We must teach aspiring physicians about systems science. Medical school curriculum should emphasize homeostasis and health rather than only disease and diagnosis. We talked about biosocial, what was it? Biopsychosocial, the biopsychosocial model. Anybody study the biopsychosocial model in medical school? A few of you? What a crock. You know, they said that and then they never mentioned it again. In functional medicine, we have created systems and tools to help you help patients make real change. And this idea that one disease, one cause is really dead. Here we have depression. We now know that depression can, a major contributor, not necessarily the cause, but a major contributor can be social isolation or omega-3 fatty acid imbalance or thyroid issues or vitamin D or prediabetes, arthritis, rheumatoid issues, autoimmune issues, antibiotic use. We used to think that the antibiotics had some as yet undiscovered effect on the neuroendocrine axis. No, it just changes the microbiome. And you know, I used to think that we had a microbiome that was, we were carrying around like some bugs. And then it became obvious to me that there was probably this function there. Then it sort of escalated to, gosh, I think this is an organ, you know. It's more cells and more active genes than the rest of the body combined, and a metabolic activity that rivals the liver, maybe about the size of the liver in terms of mass. And then I discovered that it really influences behaviors and mood and physiology. I started to think that maybe we were a microbiome being carried around by a human. And then more recent studies actually are suggesting that we're a superorganism, interdependent superorganism of these non-human prokaryotic, karyotic, and viral elements along with human cells. But the opposite is also true. Many diseases in one cause. Chronic inflammation is involved in cancer genesis, coronary vascular disease, inflammatory bowel disease, renal disease, arthritis, and so on. So there is much here. So let's go on to try to clarify how a systems-based approach can help us with patients with chronic disease. Oh, good. I think I'm doing good here. Very happy now. So here's what we used to think. Simple. It's easy. DNA is transcribed to RNA, messenger RNA. Messenger RNA goes to a ribosome, and it is translated into a protein, and the protein has function. Done. 7th, 8th grade. I am now a molecular biologist. And you know what? Before we knew that, that was just a lie, because before we knew that, before we even knew what the molecule of inheritance was, do you know that at first they thought DNA was way too simple of a molecule to be the molecule of inheritance? It was just thought to be a structural component, and it was actually proteins that were likely to be the molecule of inheritance. That's the kind of genius we are. We just don't know. You don't know what you don't know. But before we knew what the molecule of inheritance was, we knew from twin studies that, you know, this idea in the lay press about nurture versus nature, we've known it was we knew it was nurture all along. We've known since the 30s, maybe even before that. It's not the DNA. And so now we know that environment is most of the influence. In some instances, 90% of the influence, certainly 30% on average, and that DNA is under methylation control, whether or not it even translates or transcribes. Copy number variances mitigate some of the SNPs that we're all so freaked out about. People come to me with their 23andMe and they go, oh my God, I'm a mutant. I'm going to die by Thursday. What am I going to do? It's like you look at it and go, yeah, it's pretty normal, actually. You know, I mean, let's get a grip. Epigenetic effects are huge. Then that is translated to RNA, which is also under methylation controls, also under copy number variant control, also under epigenetic effects. And then proteins, also under methylation controls, epigenetic effects, post-translational changes. And there is more control, feedback, and interdependence than we previously thought. You know, we're taught this very simplified Krebs cycle, but the reality is this simplified diagram on the right. And if you think that you're going to put some nutrient, some little cofactor vitamin up in the top left-hand corner, and it's going to make some predictable change in the lower right-hand corner, you are suffering from sophomoric delusion. It is not that simple. In fact, it's complicated. We have this complex DNA of all these SNPs, these single nucleotide polymorphisms. And, you know, there are people out there that say, well, if you have 677T MTHFR, well, that codes for 50% of, you know, the activity of the wild type. So you're going to have problems. And don't take folic acid because that'll kill you. You got to take 5-methyltetrahydrofolate or folinic acid. Except in my practice, where we measure methylation, we find that people with the aberrant SNP are no more likely in my practice to have aberrant methylation than people with the wild type, because there are so many other controls related to the gene networks, the diet, the environment, the lifestyle. And then the complexity is greater because we have all these neural networks and we have all these gene array kinds of things turning on and turning off all the time. And that's not even to begin to talk about the microbiome. We are, as I said, outnumbered in both number of cells and number of active genes. Hundreds of species doing all kinds of things. So, you know, population medicine versus personalized medicine. So in a population-based study, you know, you look at 10,000 people in a multi-centered, randomized, double-blinded, placebo-controlled trial, and what do you get out of that? You get average. And as I'll show in a second, average is very narrow. So this pharmacogenomics business, pharmacogenomics is certainly probably better than, you know, just a WAG, which is the way we usually do it. But we know, the pharma scientists know that drugs work really well for about 30 to 40% of the population, which happens to be roughly plus or minus a half a standard deviation. So it's a very narrow segment of this bell-shaped curve. And it gets worse as it falls off towards the tails. And this is well known in pharmaceutical research. A blockbuster drug works really well for 30 to 40% of the population and really crappy for everybody else. And that's why you and I are in our office going, well, this is a great drug, you should try it. And it doesn't do anything, so we have to give them the next drug. And that doesn't do anything either. And then we have to give them the next drug, and that kind of works. That's why. So we have to connect the dots. And I'm going to submit to you that diseases, these chronic diseases, don't actually exist. They aren't a thing. And for a detailed discussion of that, The Disease Delusion by Dr. Jeff Bland. Dr. Jeff Bland, really the father of modern functional medicine. So what is disease? In old times, people used to think that a disease was some actual entity or thing which had somehow gotten into the body. This idea, which we now know to be true only in a few specific instances, was at one time a general idea. Here then, I say, is the highest justification for all treatment being based upon the principle of restoring disordered function to order. And this is what I venture to term functional medicine. And this is from a lecture given at Brigham Hospital in England in 1870. So the idea of loss of function has been around for a long time. In fact, this loss of function, I think, is really important. My dad, unfortunately, or I guess just as a matter of course, passed away a few years ago, but up until he was in his 90s, he was flying airplanes. So imagine him, 90 years old, and my son, 38 or so, and they're walking down the street in deep conversation, talking about the wonders of the world, and they're so engrossed in the conversation, they step out in the street and get hit by a bus. Who's going to live? The 38-year-old's going to live. If somebody lives, it's going to be the 38-year-old. And why is that? Organ reserve. My dad, as robust as he was using most of his organ reserve just to get by, because our organ reserve fades as we age. My son's using a tiny percentage of his organ reserve. He had this robust organ reserve to call upon to heal and maintain during this crisis. So, one of the tenets is function and organ reserve, and how do we preserve that? We are facing about 1% per decade increase in chronic disease. We're currently very close to half of the population has a chronic disease. It's far from the days when we thought, oh, well, sometimes you get sick, and then you go to the doctor and they get you better. Now, nearly most of us are walking around always sick. In fact, in 1994, there was essentially no state that had 22% obesity. And as of 2013, the vast majority of states have far greater than 22% obesity. When you look at diabetes in 1994, there was essentially no state that had more than 6% diabetes. Now, essentially all states have more than 6% diabetes. So we have this crisis. Diabesity, or syndrome X, or metabolic syndrome, or insulin resistance, or whatever you want to call it. And it's thought in the very near future to cost us about $47 trillion, which is more than the top 5 or 6 GDPs. And why is that? Because our genes haven't changed. Our genes haven't changed. So these are genetically identical mice. The mothers were genetically identical as well. Both the moms were fed the same mouse chow. They were both fed bisphenol A, BPA. And the one on the right was given extra methyl donors in the form of choline, folic acid, betaine, and vitamin B12. This is an example of an environmental toxin having epigenetic effects resulting in obesity and mitigating those epigenetic effects with enhanced nutritional intervention. Mind you, the mice here were not given the BPA. The mothers were given the BPA. So not only is this an interesting epigenetic effect, it's an inherited epigenetic effect. Lamarck may have been right after all. So we've got this triad of genes, environment, and phenotype, and they're interdependent. I find this graph extremely concerning. The Stroop word score is a standardized test, and there are age-specific standardized scores. And this is plotting that against their recovered urinary mercury level as measured by micrograms mercury per gram creatinine. And what we see is the normal 17-year-old is actually coincident with the medium risk of fairly high exposure to mercury. If you have low genetic risk, you're thought to be a genius on this score. You have a much higher score. And if you happen to be at high genetic risk, you're going to be delayed on average about 3 years. So while our genes are not our destiny, this is without intervention. And what can we do to mitigate the epigenetic effects of having these medium and high risk genes? And that's where functional medicine lives, is trying to understand the gene-environment interactions and how to optimize them.